Welcome everyone to today's webinar, Owning the Patient Financial Experience in a Complex Environment. I am Laura Dearda with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link that you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Leslie Richard is the System Vice President of Revenue Cycle at Catholic Health Initiatives, now Common Spirit Health, where she is responsible for setting national direction, policies, and strategies to create high-performing revenue cycle. She has more than 25 years of healthcare revenue cycle experience, including roles at TransUnion Healthcare, Sisters of Charity of Leavenworth Health System, and Centura Health in Denver, Colorado. John Talaga is Executive Vice President of Healthcare at Flywire, a leader in responsive payment solutions that are changing the way hospitals engage with patients and collect out-of-pocket balances. With more than 20 years of healthcare payment experience, John has partnered with hundreds of healthcare providers to develop and innovate patient billing and payment solutions. At this time, I am pleased to turn the floor over to Leslie to begin today's presentation.
Hi, everyone. Thank you for joining. We wanted to start today with acknowledging the coronavirus, the COVID-19 outbreak that's impacted many of our industries. While nations across the world are encouraging their populations to stay at home, hospitals and healthcare providers like you are preparing and working now more than ever. As we go through this presentation today, know that we're sensitive to what's happening in the healthcare and financial arena, and we want you to know that what we're talking about is what healthcare is like outside of a pandemic. So keep that in mind, and we'll try to address all of your questions at the end. Thank you.
Thanks, Leslie. Hi, everyone. Thanks so much for joining. This is John. And I just want to say one thing on the heels of what Leslie had said regarding the coronavirus. Thank you, everyone, for joining. I know everyone personally as well as professionally is dealing with very uncommon circumstances. And we hope that this hour is something that you can take a lot of value from. So the learning objectives that we're going to focus on during this session is we're going to first examine some of the industry cause and effect relationships that impact patient billing experience as well as self-pay collections. We're going to also review a new patient survey data that reveals some important payment preferences, so for the patient, looking at what it is that patients want. And then Leslie is going to take us through the CHI Common Spirit journey, which is really the strategy that they have laid out for improving the patient financial engagement, and then also the pre-service as well as post-service results for what they're working on. So we see a lot of, I think when you join webinars like this and see presentations, we hear a lot about the rise of consumerism. And while this isn't new to healthcare, it is vastly and ever changing. There was a time, I think with consumerism within healthcare where hospitals really sort of got a pass, right? They got a pass in the sense that, well, we're really different than retail. We're really different than these other industries that collect payments because of who we are. But that really has dramatically been changing, more so than we've ever seen it in the last 3 years, in which more and more consumers are dealing with industries and services like Uber and Amazon and even scheduling flights and making payments, where those same expectations are really now being expected from consumers for their healthcare providers and their payment experience. So more and more we're seeing providers respond to that in terms of implementing technology and implementing policies and processes to really be able to respond to what the patient wants, but still being able to manage it within the complex environment with multiple moving parts, third-party insurance, and all the complexities that go into billing a patient and receiving payment. So while these things are starting to look at, or patients are looking at, healthcare as being similar to other industries, we know that healthcare is different. There are differences. And most and foremost right now is that providers have to strategically address the affordability issue. So patient deductibles, with them being up, by 25% in the past 5 years, and really accounting for almost 30% of net patient revenue. And an average patient, for an unexpected $400 bill, almost 50% of patients cannot or struggle to pay that balance. In particular, during this financial crisis we're in with respect to COVID-19, you can imagine even the more difficulty that patients are having with respect to paying their patient bills. So these numbers can even change based on the climate and the environment, whether it's the beginning of the year because patients' deductibles are at their highest, or during a financial crisis like we're experiencing, will continue to experience. We have to constantly be responsive to what the patient's current situation is. So this has really kind of led to, you've heard the term new payer. The new payer, since the patients, account for almost 30% of the net patient revenue, the hospitals really just don't have the ability to do the same things they've done in the past. It's eroding the collectability, and if they don't respond, then it's really not going to be sustainable for them to, maintain the revenue cycle that they've been used to in the past. So I think it's really important in these things to not, as Leslie's going to go through the detail in terms of how CommonSpirit CHI is addressed directly with the patient, it's always important to kind of just hear from the patient's perspective in terms of what their expectations are and really what they want and how they want to make payments. So Flyware did a survey with payments.com, and it was published. It was a comprehensive survey with just over 3,000 respondents of consumers that have had healthcare services over the last year with a balance of at least $150. And we looked at different demographics with age, income, education, et cetera, to make sure that it was representative of what we call the healthcare demographic, which is the world. Everyone receives healthcare services, so to pinpoint this into a certain demographic is difficult because there's so many varying demographics. Well, let's look at a couple of just the highlights of this survey. And the first one is, how do Americans, pay for healthcare? And the results of this, 90% want the option of a payment plan for uncovered expenses. So when you dig into some of these details, which may be difficult to see on this slide, when you look at education and you look at income, it really does have an impact, of course, on whether patients or consumers will pay their balance in full. And then the balance has a big impact on that as well, as you would expect. But the key thing to kind of take away from this, the reason the percentage is so high of wanting to pay over time, because these are unplanned expenses. Even high income, highly educated consumers that have a monthly budget for what they're used to paying, when they're presented with a $1,000 bill that was unplanned, it can be a struggle for any American that's faced with that balance. So how popular are payment plans? So right now, on average, based on the survey, 44% of the respondents are on a payment plan. And when you look at the dollar amount, the average dollar amount on a payment plan is about $602. When you look at the balance, the average balance in a health system, it generally ranges anywhere from $900 to $1,200. So as you can see, there's still low balances, even to the level of $100 to $400, in which patients are signing up for payment plans. The 44.4% that patients are using plans for, that's across hospitals as well as ER visits. And when you look at the 44% in contrast to the 90% that want the plans, a lot of this is even having access to plans or knowing that they can get access to plans. There's definitely a gap. How do they perform? So traditionally, when I think revenue cycle organizations within the hospital have been resistant to making plans accessible. And they look at it more as a last resort. And part of that expectation was that, well, if they should be able to pay in full, and a lot of times they didn't know what the patient's ability to pay was up front. So they would just negotiate payment plans with the patient on the back end, and they would use it as really a last resort as opposed to a strategic tool for getting patients to settle and pay faster and easier. And then timing is everything. Of course, when you look at this survey, and I think one of the biggest takeaways from this survey was the overwhelming interest for patients to be receiving payment plan options at the point of service. So, for instance, when they get an estimate, at pre-registration, or when they're ready to go in for service, they're able to settle their payment if they're confident in what they owe. The other 36% of patients prefer to get the payment plan option on their very first bill. So that means if they don't or are not comfortable setting up a plan against an estimate, they still want that offer or that option to be upfront. There's only 7% of the patients that want to make a phone call or negotiate with the hospital for a payment plan. And unfortunately, most of hospitals in America, although it's rapidly changing, are still servicing that 7%. Payment flexibility matters as well. So while I think everyone that's been involved with healthcare billing over the years still wants everybody to go online, and there has been dramatic, especially in the last 3 to 5 years, dramatic success in getting more to go online, there's still 50% of the patient that wants paper statements. And what isn't reflected in the survey, the number one reason for that is to have a payment reminder. Patients are not used to getting, on a regular monthly basis, a bill from their healthcare provider. So there's fear that they're not going to get a text or get an email or electronic communication, so they just continue to get paper in order to have this payment reminder. But then there's a big group of patients that still just prefer to write checks. And while that's changing and will continue to change with the demographic shift, it's really important, I think, still for hospitals, even more than other industries, to be able to support those patients in any way they want to pay, whether it's writing a paper check to activate a plan, for instance, or if it's going online to make payments as well. And then one key thing here to note is part of consumerism, and something that's very common in all other industries or many other industries, is when you agree to pay over time, there are some fees involved for that. Hospitals aren't banks, and I think there's been a common patients have been used to in the past of just getting on payment plans with any terms with no skin in the game for them. So while during this time and certain things you can't predict, it may very well be a good time to make it easier and easier and less installments for patients to pay. There still is, the fees will change the behavior in terms of how patients self-serve. So in this survey, it shows that 66% of the patients are going to choose shorter terms or pay their balance off sooner if there's fees tied to a payment plan. And those fees can be any number of different ways of supporting that. So key takeaways, just to refresh before we turn it over to Leslie for the experience, is 90% want a payment plan for uncovered expenses. 44% of the respondents are on a plan, so we have a gap in terms of access, in terms of how many want to be on a plan versus those that are actually on it. Almost 94% of patients are willing to make payments on time or early in terms of the performance, so it's not something that has to be used as a last resort. Can be pushed as a strategy. And then lastly, timing is everything. So the more you can push the payment arrangements to pay over time with estimates up front, patients are willing to settle on those balances given the right circumstances. Okay, I'm going to turn it over to Leslie.
Thanks, John. So I wanted to give an overview of Common Spirit Health just to kind of ground you in in who we are. So we've got 137 hospitals. We're in 21 states, $29 billion in revenue, and served over 20 million people. So you can see from the map kind of where we're located, which just speaks to the size and of CommonSpirit. So when we talk today, we're gonna talk about CHI, but I wanted to let you know that CommonSpirit Health is inspired to create a sustainable and just healthcare system focused on addressing the unique needs of our patients by advocating for those experiencing vulnerabilities, fostering innovation, strengthening the continuum of care, and improving healthcare across access points. So we're providing care that extends beyond the walls of our facilities into our communities to engage and empower people. So CommonSpirit Health is relatively new. We've been here for about a year. It was a merge between Dignity Health and CHI. And so as we talk today, keep in mind that we're going to focus on the CHI location. So with that, we've got 68 participating hospitals, and we're in 12 different markets from the CHI perspective. We've got 4 core host systems, and we've been live with the Flywire solution since March of 18. And when we talk about core systems, you know, we have instances of just about everything, and so it does make the journey complex. We've got Meditech, we've got Epic, we've got Cerner with a McKesson Star back, we've got CPSI, Paragon, Allscripts. I mean, we have every version that you can imagine. So we can take you through this journey with us. And so with that, Catholic Health Initiatives, you know, we are managed through a third-party EBO. So what we're looking at is that we outsource our revenue cycle to Conifer Health. And so with that, in the complex environment of all of our EMRs and outsourcing our revenue cycle, we didn't have a lot of controls over how our patient statement formats were, what we could put on there from a content perspective. We had online fragmentation for payments. And so just so you understand, we had some capabilities within our host systems, and we had some capabilities within our early out. We had some divisions that didn't have any of those options. So it was fragmented, and it didn't give a sense of kind of that cohesive, solid platform across all the CHI locations. So we, at that point, had all of our payment plans. You had to call to get them set up through our customer service. And it was hard to get transparency into that, as you can imagine, when it's completely fragmented, to try to report out onto, you know, how many patients are we reaching, how many people are responding. So it was hard to manage the balance adjustments and all of the kinds of ins and outs that you can get with payment plans and having them come in multiple different ways. So we thought, you know, we really had an opportunity not only to increase our collections, but to really enhance our patient experience. So that was our journey. We started out with, what would it be like from a patient's view if we were going to put this in place? We kept the patient at the front and center of our decision making. So we wanted to create a personalized experience. One size didn't fit all. None of our divisions and markets in the different states were alike. So it needed to be customizable to them. We wanted to have a standard methodology. So as I said, we have multiple versions of multiple EMRs. So how do we get that like experience across all of those? And we wanted to create something that was more retail-like. So as John talked about, you know, what patients are expecting, and how Uber's come along, and Southwest and Amazon, and you think about your own experience. Why should your healthcare experience be different when you're trying to just pay your bill? We wanted the patients to be in control of managing their responsibility, and we wanted to make it easy for them. So instead of having to conform to a call center that had solid hours and was only open Monday through Friday, you know, that wasn't really easy for people. And we wanted to have it seamless. And that came through innovation. So it's hard to get a seamless experience if you're just managing it through people. So we partnered with Flywire to create this seamless experience. So we had some strategic objectives in order to get the buy-in from the people within the organizations. So we wanted to improve our statement design. We wanted to improve the delivery of that. We wanted to provide options and engage patients into paying. We wanted automated support, and we wanted to drive this to mobile and online access. So with that, we selected a strategic workflow partner. We aligned all of this through our banking. So you can think about, it's not, when you're trying to engage with your patients on online bill pay and different payment options and all of that, you want to make sure your banking partner is in lockstep with you, because it's important that the ways that patients pay are aligned with how Treasury processes all of those payments. So we developed a new engagement model. We automated our payment plan management. We created the transparency, and we managed the risk through our PCI compliance. All of those things are really important, and they're all foundational to success. So when we first started this journey, we started from the back-end approach. And so we started, as I said, through statements, in really trying to engage our patients in understanding what their patient responsibility was. With that, we have continued to move upstream and have taken that same kind of back-end approach and moved it into our pre-service and tied all of this together with our estimation. And so if you think about how it is to be a patient, getting that bill at the end after treatment's been delivered is a different reaction. If we haven't educated them and provided them with options along the way, we'll probably get a negative reaction when they get their first statement and first insight into what they would owe. And so we wanted to create that ongoing transparency that says if we educate our patients and we can customize the patient plan at the beginning of their journey, then at the end, there's no surprise. I mean, it all becomes part of the expectation. And they already have a financial plan to support that. So we created this pre-service estimate that aligns with the post-service balance. So in developing this, we went through how do we connect all the pieces together. So you've got the host systems, you've got your banking component, you've got your estimation, you've got an outsourced billing provider, and you've got the patient statement Flywire to pull all of those things together. And so that's what we've done, is we have pulled the best of all of our systems and been able to provide a patient and our staff with a seamless approach. So the information from the pre-service and post-service balance goes into Flywire, and with that, they're able to get the patient's propensity to pay and their estimated balance or their actual balance. We can have their history, and they can then make the determination if they qualify for a payment plan or if they don't. So if they don't, they would get a pay in full statement. If they do, they get a payment plan offer. And that is presented to the patient in multiple different ways. It can be mobile, it can be online, and it can be paper. And if you think about how when you would get the traditional statements, you might get an estimate up front, and they would be able to say, you know, based upon what we know, your estimated balance is X. And they would ask for a payment or a deposit, but it never felt connected to the actual statement that you got post-service. And so our intent here is to tie it together. So if I set up a payment plan in advance of service, then when I get my statement, there's an acknowledgement of that. And so it makes the patient experience feel like we're connected in their financial journey, just as they would want us to be. The thing that we also had to consider is what happens when I get a new balance. So now that I've gone through this whole process and I have an estimate and I have a payment plan off of my estimate for service and I get my service and I've shored that all up, then what happens when I have service again? And so with the technology and innovation, we're able to then pull in the new balance and then present to the patient an adjusted offer for payment plans that is all-encompassing of the services that have been rendered. All of this then comes back into our EMR. So you don't have to live in your bolt-on environment. You can stay within your EMR and know what's happening with the patient's financial situation. Our customer service, which, you know, when you're in multiple states, they're probably not local, and so they're able to see all of this, and they can activate the same experience for the patient through the call center. So in the environment that a patient wants to actually call in and talk to somebody about their options, the same delivery methods are presented to them. And then we can process the payment through our PCI compliance software. So we talked a little bit about the free service, and we're going to take you through kind of the appointment scheduling, estimation, payment plan options, and then the self-service piece of that. So picture yourself that you're going to schedule for a procedure and you have insurance and you know you have a deductible and co-insurance and all of that, but you have no idea what that procedure is going to cost you. So your doctor says you have to have it done. We're able to provide an estimate to the patient, and that estimate is through a partnership that we have with an estimation solution vendor that pulls in our contracts and our claim history and our charges and is able to determine what your out-of-pocket would be for that procedure. What we've added to that is the ability to set up a payment plan based upon that estimate. And the nice part about doing this through innovation is it takes away all of the grids and sticky notes and all the things that you have around your desk to say, well, if it's this, you should do that, and vice versa. This gives you all of your options and it presents it in a way that allows the staff to react without having to go and guess and pull out grids. So we've got the information that can come in that will trigger the digital notification to the patient. So in order to meet all of the compliance, we have to have the patient acknowledge that they want to set up a payment plan prior to service. And so all of those acknowledgments are in place. So they would get a text that would self-direct them to click on a link to be able to set up a payment plan prior to service. Once they do that and they complete their activation, they get a confirmation. So in our digital world where we're all running around on our phones and want to be able to pay our bills just like we do our cell phones and car payments and different things, this is aligning with that industry that says we'll be mobile, we'll allow you to do everything remote as well and put you in control of what your payment plan will look like. So they can enter their payment information and they can put a card on file and they get their activation as complete. So there's their digital receipt. So that's the pre-service. And so then from a post-service perspective, we wanted to take the approach of one bill, one balance, one payment, personalized payment.
I think we're having difficulty hearing Leslie. Leslie, if you're out there, let me know when you come back. Unfortunately, everyone working from home, she is on her cell phone for this presentation, so I think maybe she just got to drop out. So Leslie, when you come back, let us know. I can at least continue the conversation while she's out. I'll pinch hit. So with the personalized payment options that Leslie's referring to, it's important to provide this as a connected experience. So whatever the patient did or didn't do at pre-service, it has to be connected when they receive their very first bill after adjudication. So as an example, if that patient was signed up for a payment plan at pre-service, they would receive a statement that would just tell them that their next payment is due, so it continues. Any adjustments that happen within that payment plan after adjudicated balance would be adjusted for that patient automatically, and they would be able to continue making their payments. But there's still going to be patients that either made a down payment, didn't pay at all, or whatever the scenario is, and they would receive their first statement, and we have to respond to that as well. So this is an example of a CHI consolidated statement. And again, this, as Leslie mentioned, this is standard across all of the facilities, all of the different regions within CHI, regardless of what EHR that they're using. There are some idiosyncrasies between each one, because in Epic already does some level of consolidation versus Meditech and Star that don't. So there's some kind of customized ways of showing that. So this is an example of how that consolidation looks. Leslie, are you back? I think I can hear you.
I'm back.
Okay.
Sorry about that.
Okay, you're back.
My phone was lost. So
no
my
problem.
apologies.
I was pinch hitting for you, so I hope I didn't break your rhythm. But you could see
No,
where
it's all good.
So go ahead. I'll take it from here.
Yeah. So on the consolidated statements, I think that what's important is that we're pulling all of this together and presenting the patient with options for all the services that have been rendered. And the example that I like to use with this is, if you consider like a toll bill, or you consider like your Visa or anything like that, you don't get a bill per transaction. And so in trying to create the patient experience, we wanted to say, this is all of the services that have been rendered at our facility and presented in a more consolidated fashion. And you can see that they have all of the options are there for them. So the other piece of this is presenting the patient with options right on the statement. So historically, it would be, you get your pay in full. This is your balance. And if you wanted to have a payment plan, then you would have to call. And so it didn't allow for the patients to react to it in a way that engaged them in the journey. And I know that, my husband had services and he got a pay in full, and he's like, well, what if I can't pay that? And it was, you have to call. So this allows the patient to see that there is options, and we're putting the options right in front of them so that there's no guesswork, which we have found that the patients react well to. We talked about having a multi-modal engagement. So you still get your paper. If that is where you want to react to your statement, you get your paper statement, you can write a check. We've got online, we send emails that you can go online and pay, you can get your reminders, and we've got text. So the digital payment and self-service convenience allows for the consumers to self-service. And if you think about the way that you pay your bills and how you react to them, having self-service, having automatic payments, having reminders, being mobile, doing the direct pay, having online management, that's how all of the other industries have connected with us. And so we want the healthcare experience to connect in the same way. Online offers, this is how we're able to communicate to our patients that they're on a plan. Basically, we want you to know you have successfully completed what we've asked and you've selected the plan that meets your financial needs. We can auto-add new accounts to that service, so you continue to have service, you can add them in. It's basically just changing your amount or the terms. And you have a control panel where the call center and the patient access staff can manage this, and they also creates the guardrails so that they feel like they're protected through the policy and everything else to deliver this to the patient seamlessly. So what are the results? As I said, we had patients that had to call into our call center to be able to activate their plans in our previous situation. So now we're up to 74% of patient-activated payment plans. We've improved our statements and our online experience. We've increased our self-pay cash collections. We've got insight into our plan terms, which we're now running around 12 months. We have online payments increase, and we've got a lot more insight. And so we're able to make decisions about where we want to go with financing and different things that we may want to offer in the future. And we've increased our patient experience and transparency. So where are we going to go from here? From here, we would like to be able to have financing options for our patients. And part of that is, how do we keep the patient engaged with us as a healthcare provider and provide more long-term options? So it's more about where do you insert this? And we would consider this to be an extended payment plan. So you've got your pay up front, point of service, payment plan offer. You can pay after service through a payment plan offer for your mobile or online. But then what if we wanted to relieve our AR and have the patient have an extended payment plan and go longer than let's just say the 12 months. So we wanted to lower our financing rate, we wanted to reduce the risks, and we really wanted it to be seamless. So with that, we have embarked on many different avenues of being able to finance this for the patient. But our main point that I'll leave you with is that we want the patient experience to be seamless, and we don't want to do a handoff to other vendors along the way. We want to keep our patients, we want to protect our patients, and we want them to have a financial journey that supports the clinical experience that they've had. So with that is our financial journey that we've taken with our patients. I will say that in the midst of COVID-19 and the coronavirus and all the things that we're doing today with this pandemic, we have been able to quickly adjust and be agile in our approach and our partnership between CHI and Flywire to make adjustments for patients that have been financially impacted, not just through the treatment of COVID, but also what is done to them financially, to present options to patients that is more of a COVID relief. And those are the things that I think is unique about where we are on this innovation and digital journey that we're embarking on, is the ability to quickly respond to what's happening in healthcare and keep the patient at the foremost of our decision making. So I know that you are all faced with challenges around COVID today, and I think that keeping the patient and keeping that situation top of mind allows you the ability to make adjustments where needed. So John, I will turn it back to you.
All right, well, thanks, Leslie. And so that's the end of our formal presentation, and I think there's been some questions that came in. We're ready to take those now.
Thank you, Leslie and John, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. We do have a few questions to start off with. So the first question that I have here is for Leslie, wondering how are patients able to enroll in this platform, and is this proactively introduced to the patient at all CHI facilities?
So thank you for that. I would say we're at different journeys based upon the CHI location. So some of them are at the beginning, some are in the middle, and some are towards the end. And so we have some of them that have this presented to them on statements. We have some that are part of estimation and presented to the patient verbally through the pre-registration process, and then they get an authentication through a text. And we have others that are really basic until we can get their whole platform totally live. So we have multiple places that we are. All of them different based upon the EMR and based upon what's happening in the environment of that state.
Thank you so much for clarifying that, Leslie. Another attendee is wondering how CHI monitors and measures the accuracy of their estimates so they set appropriate expectations for the final balance.
So that's absolutely a concern of ours, and we have gone through some rigor testing. And what we were able to do through all of that process is we have actually flagged certain CPT codes that are high accuracy versus ones that have a lower accuracy. And some of that is just the types of procedures. You know, surgical procedures tend to be a little less accurate. So if it's high accuracy, we feel that we can go with the asking for the full amount and putting in the payment plan for that. If it's a lower accuracy, we do more of a deposit, and we have scripting around how we coach our staff to talk to the patients so that we set the expectation on whether or not it's deposit or full estimate, and that post-service, the adjudication of their statement will reflect the remaining balance.
Got it. Thank you for outlining that for us. The next question from the attendee is, do you offer a discount for payment in full on the back end?
So on the CHI side, we do not offer a discount for payment in full on the back end for insured patients. We do have a self-pay discount that is applied to all patients, regardless if they pay at the beginning or at the end. But at this time, we are not offering discounts for insured patients.
I see. That makes sense. And then, you know, for either of you, we have an attendee who's wondering whether the study revealed any customer preferences to move away from high-deductible health plans in favor of PPOs because of the predictability of the premiums versus the unpredictability or the burden that could come with the high-deductible health plans that would accompany out-of-pocket payments.
Yeah, so I can address that. So that's a great question, and we did not include in the survey attitudes or preferences towards health plan selection. It was just around the balance that they have due and what their preferences for payment are.
Got it. Makes sense. The next question we have here is, how do you view the role of payment plans versus using third-party creditors, such as care credit?
So I would say that, you know, care credits and some of those are limited from a hospital perspective. A lot of them are are real clinic and niche kind of environments, and so we made the decision that we would select a partner that would be full service, and so that was our decision that we made, and so that we could control for the payment plan offerings and control it with it being kind of in-house instead of outsourced to a vendor like a Care Credit.
Perfect. And the next question we have here is, what percentage of the patients get approved for the payment plan? Leslie, if you could outline that a little bit for us, that would be extremely helpful.
Yeah, so I mean, we have policies around payment plan offers, so setting a minimum, so if you think about if your balance is less than $100, do you want to offer a payment plan? We look at those numbers. I think then, there's factors of propensity. There's different ways that we can move patients through the cycle of whether or not we offer them a payment plan or we work through our financial assistance, or if there's things that maybe are more of a hardship. And so we take all of that into consideration as we think about what's the best plan offer for that patient's circumstance.
I see. That's very informative. Thank you. And then another attendee is asking, what's the overall collection rate on those engaged payment plans?
I can answer that, Leslie.
Okay.
Unless, yeah. So generally, the collection rate on when it's active on a plan is about 85%. So that, just to be clear and set the right context on that, those are patients that have activated a plan, are making payments through conclusion of their plan. So collection rate is more around collecting the entire amount that is part of the plan as opposed to just, a monthly payment.
Got it. That makes sense. Another question we have from the attendees here, I believe this one will be for Leslie as well. How long did it take for you to implement your program?
Well, that's usually a question that I get, and I would tell you that we're still implementing. So, we started in March of 18, and because we keep adding more to this financial journey, we're still in process. So, if you were to take a typical, I think we did it pretty fast. I mean, I think that you can stand up portions of it really fast. But when you add to it and you bring in the connection to estimation and you want to bring in a financing component and all of those things, it adds more and more time to it. So I would tell you that we did it in a matter of months, but it's been a couple years and we're still perfecting.
That's really helpful to understand. Another attendee is wondering, when you consolidate accounts on a single statement, are you still able to age at the account level? John, if you're able to jump in here.
Yep.
Or Leslie.
Yeah. So.
Yep. Okay.
So with any of the there's two important parts there is the aging at the account level. If it's Epic, it's HAR, or a transaction on the PB side, and then if it's Meditech or Star, then it's at the account level. But the accounts continue to always age at the account level. The consolidation is really around a presentation to get the patients to, engage and make a single payment or set up a single payment plan with one document, one email, one text, one online login. But everything is still aged at the account level if there's anything that's past due. And then when they're on a payment plan, there's rules around posting in which there's flexibility. So the flexibility can be around first in, first out as they make payments on their plan across multiple accounts. Or there is also the flexibility to do a distributed balance across accounts so that you don't have really, older accounts with high balances, preventing newer accounts with lower balances from getting, any funding against that account. So there has to be a lot of flexibility around that, but the simple answer to that is everything is still managed at the individual account level.
I see. Thanks for clarifying that. And John, I have another question for you, I believe. Are the patients still charged $395 monthly when they choose a payment plan?
Yeah, so to clarify that, the service fee that was mentioned in the question is only for payment plans. So if a patient just wants to make a single one-time payment, there's no fees around that. It's only if they choose, with their different options that they have with different terms, to activate a plan that a service fee per installment is included. And that service fee would go away if and when they pay their balance off in full, either at the conclusion of their plan or if they pay it off early.
I see. Thanks for clarifying that. And along that route, Leslie, we have another question here. How are your patients reacting to the service fees?
So another question that I get quite often, at the beginning I would tell you that we were nervous. I mean, we're a faith-based, mission-oriented, non-for-profit healthcare system. And so we said we would implement it and we would watch it, and that we just weren't sure. And we've been live, for a couple of years on this, and there's only been a handful of people that have had a negative reaction. And so I do think that it goes along with the survey that John was presenting, that patients expect to kind of have a service fee, if you will, if they're going to have an extended payment plan. And so I think people have embraced it. I would say that the complaints that I have fielded have been minimal. And I do think that a lot of it comes into how it's set up from a expectation standpoint. And so having patients understand that there's no service fee if they pay in full, and if they opt for a payment plan that is attached, I think has helped with just setting that expectation and not having a negative reaction.
Got it. That's very helpful. John, I feel the next question is for you, or you'd be able to answer this one. When a patient enters the 12-month payment plan, is the account still on your active AR?
Yeah, go ahead, Leslie.
Yeah, we do not move our AR off for payment plans. And so when we talked about going into extended financing and stuff like that, then we would evaluate relieving our AR. But at this point, all the payment plans, since it's basically in-house managed, stay on the AR.
I see. Perfect. And then one more question for you both. How are you managing the payment posting when an estimate and self-pay balance are both on a single payment plan?
You want me to take that, Leslie?
Sure.
So again, everything is rules-based, right? And you can keep in mind, if there's a single payment plan, if the rule is the oldest account is going to be based on the data service. So if you have a data service, let's say a balance that's been out there for 30 days, and then they activate a plan off an estimate at the same time as they activate the plan with the older service, the posting would be against the oldest account. In this case, it would be the service that was already had a balance due. Again, so those are rules-based. So, if there was a rule that somebody wanted to post the payments against an estimate first for whatever reason, or a balanced distributed balance, those rules are something that can be implemented as well.
Great. Thank you so much for answering that. Leslie and John, do you have any final thoughts?
Go ahead, John.
Yeah, I think that my only final thought is, I think top of mind for everyone is the environment with the coronavirus, and we've spent, I think, the last 4 days, with hours of setup to really create what I think was a fantastic partner solution to respond to the financial crisis that's been a result of the coronavirus. And I think what Leslie mentioned earlier is this is not about a vendor just providing all the services to the provider or the provider dictating to the vendor what it is they want. I think the partnership and collaboration is so critical to be able to work with the teams, have the right level of support to adapt for really unpredictable things, whether it be this financial crisis or other things that are going to come up that we haven't been able to yet predict. So that would be my takeaway, is making sure that you're working with the right partners and working with also the right providers.
I agree. Thanks, John. I would just say that, putting the patient at the forefront of your decision making is going to keep you on your course, and in the spirit of transparency and all the rules that are handed down through healthcare, being able to be agile and making adjustments is key to success. So I appreciate all the people that are on this call and all the things that you're going through to combat the COVID-19 influx. So thank you for taking the time out of your day to meet with us for an hour.
Well, thank you both, Leslie and John. That's all the time we have for the webinar today. I appreciate your time, Leslie and John. This has been an excellent presentation, and thank you to Flywire for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.